Good evening, everyone. A warm and cordial welcome to all the esteemed dignitaries, respected speakers, and dear participants. On the occasion of World TB Day, the Department of Community Medicine, KMCT Medical College, is proud to organize this national webinar series 2 on TB elimination in India, status and strategies. Myself, Dr. Nivya, Associate Professor in the Department of Community Medicine. It's my privilege to coordinate and host today's session. This webinar is part of our national webinar series, which aims to address key public health priorities and bridge the gap between policy and practice. We successfully conducted Series 1 on leprosy, and today's session marks Series 2, focusing on TB elimination, a major public health priority for India. We are also excited to continue this academic initiative with our upcoming Series 3, which will focus on decoding India's NP-NCD program in connection with World Health Day on April 7th. Dear participants, I kindly request to mute your microphones, and you may post your queries in the chat box towards the end of the session, and we'll be addressing following that. Now, to formally begin today's program, it's my privilege and honor to invite Dr. Jayakrishnan T, Professor and Head, Department of Community Medicine, KMCT Medical College, to deliver the welcome address. Over to you, sir.
Good evening to participants from all over India. This is the second episode of our Public Health National Webinar Series. We are conducting this program in association with District TB Cell, Health and Family Welfare Department, Kozhikode. Collaboration of Academic Department with Health Service Department. We consider this link is very important in public health. Today is March 24, is World Health TB Day. Our topic is TB elimination in India, status and strategies. In the same day, on March 24 in 1882, at Berlin, Germany, at Physiology Hall, Robert Koch announced his discovery of TB bacilli on that day. At the same venue, he concluded his talk with the words, "If I cannot stop this peril, my life has no meaning." Still, TB, the oldest challenge is attacking human being, is continuing. This year also, the theme is "We can end TB." We public health people consider TB as an indicator of social development. By addressing social determinants, most of the developed countries over the world controlled TB in last century itself. As per the latest 2025 World TB reports, India harbor 25% of the world TB cases. This is equal to annual incidence of 25 lakh cases. We are also having 3 lakhs deaths annually. We are aiming elimination of TB very early than World Health Organization. As per the National TB Survey, still countrywide, we are having incidence rate of 192 to 10 per lakh cases per year. Our state Kerala having incidence rate, compared to other national states, we are having the incidence rate 100 per lakh cases. Can we end TB? Yes, we can end TB together. Today's speakers, Dr. Aparna Mohan, WHO Medical Consultant, and Dr. Dhilmon, District TB Officer Kozhikode, will elaborate our country's efforts towards it. I welcome both of them. In their absence, I welcome Dr. Nawaz KM, Chairman, KMCT Group of Institutions, Dr. Aisha Nasrin, Director of Executive Trustee, KMCT Group of Institution. Also welcome Dr. Vijesh Venugopan, Principal, KMCT Medical College. I welcome all of my colleagues from my department and all KMCTians and other professors and doctors and PGs from all over India. Ending TB is not a policy goal, it is a moral responsibility. Also, I welcome Dr. Nivya, the host of the day, and over to Nivya to coordinate the program. Thank you.
Thank you, sir, for your insightful words. We now move on to the scientific sessions. It's my privilege to introduce first speaker, Dr. Aparna Mohan, a dedicated public health professional who completed both her MBBS and MD in community medicine from Government Medical College, Thiruvananthapuram. Her commitment to public health was evident early in her career. as she played a vital role as part of the state lab team during the COVID-19 pandemic response while pursuing her post-graduation. In 2021, immediately after completing her MD, she joined the World Health Organization as a medical consultant, where she has been actively contributing to the National TB Elimination Program by providing technical expertise and strategic guidance. She is also actively involved in academics with several research publications and presentations at international conferences. She'll be speaking on the topic India's strategic roadmap for TB elimination. Ma'am, we are truly honored to have you with us today. I request you to kindly take over the session.
Thank you, Nivya. First of all, let me thank KMCT Medical College for this opportunity to interact with you all on this World TB Day. And without wasting time, let me move directly to the topic India's TB Elimination Mission, the policy framework and the strategic roadmap. So I will begin by discussing the current scenario, followed by the strategies India is adopting to achieve TB elimination by 2030, and finally, certain key areas where the Kerala is currently focusing on. And let us start with the Sustainable Development Goal. Okay. By the way, I hope the screen is visible and the slides are moving.
Yes,
right?
ma'am.
Okay, thank you. Okay, so let us start with the Sustainable Development Goal targets for TB elimination that majority of my participants will be knowing about it. That is, we aimed for a 80% reduction in TB incidence rate, a 90% reduction in number of TB deaths, both with 2015 as a baseline, and 0 families to face catastrophic costs related to TB. But even at the global level, regarding the TB incidence rate, we could achieve only a 12% reduction. And regarding the number of TB deaths, a 29% reduction and a 47% reduction in number of families or percentage of TB affected households facing catastrophic costs. So while we acknowledge that the country has not fully met this target, we can now align our efforts with the Sustainable Development Goals timeline and aim to achieve them by 2030. And here is the progress with respect to SDG targets for India. That here we have achieved a 21% reduction in TB incidence rate, a better reduction in number of TB deaths, that is 25% reduction when we compare the global figures. And regarding the percentage of TB affected households facing catastrophic cost, as of today, we do not have the data, but our national survey is under progress. Hopefully, we will get evidence on the same in next 3 or 4 months. So this is the geographical distribution of high burden settings around the world, and we can see a big circle above our country, that is India. So I will show you one more image which will give you a better picture on the contribution of India to this TB patients across the globe. That is, it's very clearly we can see that around 25% of TB patients are diagnosed from India. So this is why every single citizen of India has got a role in TB elimination. This is why we say that people have to move, people have to make voice, people have to be responsible for their own health, for the public health. So if India can eliminate TB, the world can eliminate TB. So even a 1% achievement from our country, it will reflect in a global platform. This is just a snapshot of current scenario based on the Global Tuberculosis Report in 2025, published by World Health Organization. Definitely, it carries the data from the calendar year of 2024. On a global level, we had around 8.3 million patients diagnosed with TB. While India, as I said earlier, around 25% of this global patients comes from India, that is around 26 lakhs. Kerala, in the country, it is a low prevalence settings, and we are still having around 20,000 TB patients diagnosed in Kerala. And coming to the death, we had around 1.1 million death among the patients who were on anti-tuberculosis treatment in the year 2024. And in India, 3 lakhs death. And in Kerala, definitely we too had around 1,800 deaths. This is some basic facts about TB that every medical person must be knowing for our information. That is, TB is still the world's leading cause of death from a single infectious agent, and a quarter of the global population are infected with TB. So that is what we call as TB infection now, previously known as latent TB. And regarding a profile of people diagnosed with TB or people with TB. So now we usually do not call the name cases. So it's a kind of a humanitarian approach or the ethics to call them people with TB. So that is called PWTB. Among all diagnosed patients or the people with TB, 90% are adults and 55% are males, and 84% of total diagnosed patients have got disease in their lungs, that is pulmonary TB. And this is the reality. Without treatment, around 50% of the people with TB will die. And if they take good quality treatment, 90% of the lives can be saved. And definitely, without addressing the broader determinants of TB, that is poverty, undernutrition, HIV infection, smoking, and diabetes, we are never ever going to eliminate TB. But that is something beyond a single department of health. So every single department, line, governments and the community, citizen, everybody has to work for that. My main topic is the strategies for TB elimination. So the strategies for TB elimination is very much closely in line with the epidemiology of TB. If only the medical persons are attending the webinar, they will be knowing this basic epidemiology of TB that we start learning from our first year of MBBS. That is, if there is an untreated pulmonary TB patient, he can give infection to his healthy contacts, and among those, a small percentage will get the infection. That is, they are TB infected individuals, and even a good percentage of TB infected persons can revert back to healthy persons if their immunity is strong and the level of exposure is very small. But what if the immunity of this exposed person is low due to multiple reasons, or if the exposure level is very high, like a household contact or a workplace contact or a very near friend who this patient interact on a daily basis, then there is a chance that this person cannot eradicate or remove all bacteria from his or her body. And that person is considered as a TB infected individuals. And these people slowly progress to another level that is called a subclinical TB. The difference between the TB infected individual and the subclinical TB is that in TB infected individual, the person will appear completely healthy. There will be no symptoms, no signs. Chest X-ray will be normal. But if you do a CYTB test or a IGRA test, that will be positive. And when it comes to the subclinical TB, the patient mostly do not have symptoms or a very mild symptom. That is not a problem for the patient. But definitely, if we take the chest X-ray, I am talking about the pulmonary TB, okay? So if we take a chest X-ray, there will be some abnormalities in the chest X-ray that may not be a defined sign of TB, like a cavity or consolidation may not be seen, but some abnormality, that is a deviation from normal chest X-ray, can be seen. And if we collect a good quality sample, an early morning sample or a supervised spot sample, and we offer a NAT test, that is nucleic acid amplification test, or even a culture, that turns out to be positive. The advantage of diagnosing a person in this subclinical TB is that the person, there will be a very good outcome for this person, and also the transmission rate will be less in the community, almost zero. So the community transmission can also be prevented at this stage. And definitely the next stage, we all know, if a person we cannot identify at the subclinical stage, definitely the bacteria multiplication will happen, the disease progression will happen, symptoms will start developing, the condition worsens, and the person will become a patient with TB, with all the signs and symptoms of TB. The TB diagnostic test results will be positive if we do a organ specific test. And again, if we do not offer treatment for the person, there is 50% chance that the person will die. I do not say that it is 50% chance. With all the comorbidities, living situation, and the social factors, there is high chance, more chance for the person to die, and all this disease transmission will happen. So all the strategies for TB elimination focus on this cascade of TB epidemiology. The best effective intervention to reduce the TB incidence is to prevent transmission of disease from the symptomatic person to his healthy contacts. So how can we achieve the same? First one, food assistant to household contacts. That means we all know nutrition and TB has got a very close relation. Poor nutrition leads to TB, TB leads to poor nutrition. That is a vicious circle. So if there is a TB patient and there is a malnourished family member, there is high chance that that person is going to be the next TB patient. So if we can address the malnutrition and the other comorbidities of that contact, definitely that chain of transmission can be broken to some extent. Next one, airborne infection control practices, then BCG vaccination, address the broad determinants of TB. And the last one, TB preventive therapy. So why I kept this TB preventive therapy in a big block is that that is something that every one of us must learn, must advocate, and must practice. And there is one more block that we can do at our end, that is airborne infection control practices. Excuse me, any disturbance? May I continue?
Yes, ma'am.
Okay. So this is another thing that every healthcare professional must practice at our own level. That is a cough ethic and better ventilation and airborne infection control practices at our workplace, especially at our workplace. Because I am not saying this one specifically for TB, we all know for all airborne infection diseases, this must be practiced at individual level, at our OP rooms, IP care rooms, and the waiting area. So what the best we can do, please do it. Structural modification may not be feasible at all places, but to open the windows, ensure cross ventilation, follow cough ethic, provide mask for the patients with chest symptoms at OPD, screening for all OPD patients and the IP care patients for the symptoms of cough or some kind of respiratory distress, and offer them appropriate tests. I'm not saying always offer TB test alone. you offer, that can be an H1N1, that can be a COVID, that can be a Nipah or whatever. So offer the best appropriate test and provide isolation facilities wherever feasible. Now coming to the TB preventive therapy, this is the single most intervention that can bring a rapid reduction in TB incidence in India. And who all are eligible for TB preventive therapy? I have mentioned earlier that 1/3 of the global or 1/4 of the global population is infected with TB. That is, if 100 people are attending this webinar, 25 people are already infected with TB. So there is no point in giving TB preventive therapy to all these 25 people. We need to focus on people who are at a higher risk to develop TB in future. So these are those people. One, household contacts of patients with both microbiologically confirmed and clinically diagnosed pulmonary TB. So the site of the disease is more important. Whether it is microbiologically confirmed or clinically diagnosed doesn't matter. The next one, people living with HIV and their children living with HIV aged above 1 year, and children living with HIV less than 1 year if they have a contact history of TB, and other certain clinical risk group like patients who are on immunosuppressive therapy, patients diagnosed with silicosis, patients on anti-TNF treatment, patients registered for or undergoing dialysis, patient registered for organ transplantation or already completed that procedure or awaiting organ transplantation, and definitely healthcare workers, because all the healthcare workers are at a increased exposure risk. And healthcare workers, it is not a mandatory activity, it is on a voluntary basis, at least in Kerala. And coming to TB infection test, please note that again, every single individual who fall into those category need not take the TB preventive therapy, at least in Kerala. India follows two kind of policy for TB preventive therapy. One is a test and treat policy. It means you test for TB infection. Please remember the image that I have shown earlier. You do a test and make sure that you belong to a yellow category, that yellow man who is TB infected. And if you are positive for TB infection test, take TB preventive therapy. Or another policy is just treat only policy, because here the people, we are not waiting for a CYTB or IGRA test. Directly go for treat policy, usually a high burden settings, and the settings with the resource limitations are following the treat only policy. Since in Kerala we have got adequate resources, lab facilities, and the consumables, as of now we are following a test and treat policy. These are the two tests currently available for the diagnosis of TB infection test. Please note, these are not diagnostic tests for TB disease. If a person comes with a CYTB skin test positive or IGRA blood test positive, doesn't mean that the patient is having TB. We have currently no authority to tag that person as a TB patient and start ATT. It only indicates that person has got TB infection. I am focusing more on CYTB because this is comparatively newer when compared to IGRA. IGRA is, well, every healthcare practitioner will be knowing because it is in place for the last 3-4 years. CYTB was introduced last year. It is a next generation skin test for the detection of tuberculosis infection, and here also we use the same antigens that we use in IGRA, that is ESAT6 and CFP10. This also measure the immune response of a particular patient to this person, to these antigens. And how we administer, it is an intradermal injection of 0.1 ml, and then we will interpret after at the interval of 48 to 72 hours. If there is an induration more than 5 millimeter, we consider that the person has got TB infection. So it is very easy to use, point of care test. It can be conducted at a sub-center level or Ayushman Arogya Mandir level. And currently it is approved only above the age of above or equal to the age of 18 years. This might be resonating with the old test that we all were used to, that was Mando. Please note, the Mando reagent is different. This is an advanced one which does not give any cross positivity with the BCG vaccination. And this is for the diagnosis of TB infection approved above the age of 18 years only. So these are the TPT, currently available TB preventive therapy regimens for the treatment of TB infection. And there will be a little difference when compared to other parts of the country and Kerala. And this is the regimens and the category of people that we consider while we decide a particular regimen for TB preventive therapy. If it is people living with HIV and children living with HIV, we have two options. One is a 6 months of INH, which we all are used to for many years. That is a daily regimen. Or there is a 1 month of isoniazid and a rifampicin regimen. That is again a daily regimen. Here we do not do a CYTB or IGRA. Again, household contact of less than 5 years, we do not recommend CYTB or IGRA, but the regimen we give is 3RH, that is rifampicin and isoniazid. This is also a daily regimen. If a household contact aged above 5 years or any other clinical risk group that I discussed earlier, then they require IGRA or CYTB depending on the age. Age means 5 to 18, we will give IGRA. Above the age of 18, we will give CYTB depending on the availability. And the regimen, less than 15 years, we will be using 3HR, a daily regimen. And above the age of 15, we have got a weekly regimen, which is very easily tolerated. The only issue is that there is forgetfulness is high or missed dose rate will be high with this weekly regimen. Weekly regimen means isoniazid and rifampicin once in a week for 12 weeks. 12 weeks means 3 months. That's why 3 HP. Or if there is a person who always miss dose or there is some adverse drug reaction to HP, then definitely we can shift to 6H. And other clinical risk group, similarly, we can either give 3 HP or 6H. Point to note here is that though we call it as household contact, it includes all close contacts, including the workplace contact. So our household contact means a person who came in contact with this pulmonary TB patient before his or her treatment initiation for at least 1 day or night. Okay, so this may be a little confusing, but I'm not probing again into that definition. Please do understand this household contact includes both workplace contacts, very close neighborhood friends and all. This is the cascade of TB preventive therapy. First, do a very complete, detailed contact tracing as per the definition and ensure that we rule out active TB among all these contacts, because only absolute contraindication for TB preventive therapy is active TB. So first of all, rule out active TB. For the same, we have to do two things. One is ensure that the patient does not have any signs or symptoms of TB through clinical evaluation. Next one, take a chest X-ray. And chest X-ray must be normal. What will happen if the chest X-ray is abnormal? That could be a case of subclinical TB. Then followed by that, do a NAT. And if it is negative, okay, you can proceed with TB preventive therapy. So the first foremost thing, rule out active TB. Then do TB infection testing, either CYTB or IGRA, as I mentioned in the previous table. If applicable, if it is less than 5 years, we need not do. And do the TB preventive therapy. So initiate the TB preventive therapy and regular follow-up to be done. So this is the cascade of TB preventive therapy. So then next thing, further to address the TB elimination or to reduce the TB incidence to mortality and everything, our next target is the subclinical TB and active TB. What we can do here is early diagnosis and early treatment initiation, complete treatment, and 2-year follow-up. These are the main factors that that is applicable for the both subclinical TB and active TB. Again, it is not feasible to screen for TB among the whole population. As I said, the subclinical TB will be asymptomatic. So we cannot offer symptom screening or chest X-ray screening for the whole population. So whom to target? This is called vulnerable groups, because there is a selected group of people who are at high risk for TB. That could be due to clinical reasons. That could be due to clinical reasons can be HIV, diabetes, immunosuppressive therapy, anti-TNF treatment, etc. Other thing can be due to social factors, like people living in prisons, poverty, then slum people, etc. People living in the slums. And other one, geographical factors like isolated areas, maybe a tribal settlements, etc., or internally displaced people, refugees, guest workers, etc., because their access to healthcare or will be a little limited. So due to multiple reasons, these people are more vulnerable to TB. So what we can do is that actively search for TB among these group. We can search for TB among these group using two methods. One is symptom screening. Ask for symptoms of TB. If it is positive, send the person for definitive test. Like currently we recommend TrueNat or CBNat test, or even if the person is asymptomatic, offer the chest X-ray. If there is a chest X-ray showing abnormality, send the person for NAT. So this is applicable not only for the vulnerable population that we focus for the community level activities. When a person comes to our OPD or IP care facility with any of the signs or symptoms of TB, definitely offer the TrueNat or the CVNat test. And if we know the patient I am treating belongs to a vulnerable group, that is a person who is on immunosuppressive therapy, definitely I will offer a chest X-ray if the patient is asymptomatic. So this is how we can do an early diagnosis of treatment. And these are the different diagnostic modality currently endorsed under NTEP. But I need to focus here. The currently recommended tests for the diagnosis of TB are Gene Expert, that is the CBNat. Gene Expert is the company name. CBNat cartridge-based nucleic acid amplification test, or TrueNat. These are the two variants of same kind of test, or the procedure, or the methodology of the test. And microscopy, okay, we still do microscopy, but it is not a preferred first test, just because of low sensitivity, and there is no option to diagnose drug-resistant TB. And chest X-ray is currently treated only as a supporting evidence, and it can be considered if the Gene Expert, NAT test, or microscopy, everything turn out to be negative, but chest X-ray shows a sign very much suggestive of TB, then we can tag that person as a person with TB based on chest X-ray. So kindly focus on sending more samples to CBNat and TrueNat, especially extrapulmonary sample, because these are all precious sample. If we send, if we do not send that for CBNat or TrueNat on the first hand, we may lose an opportunity to diagnose a drug-resistant TB. The CDST expansion, it means the culture test that we do only at 2 laboratories in Kerala. One is at Kozhikode Culture and DST Lab, and at Thiruvananthapuram we have got intermediate reference laboratory, where we do a panel of tests to diagnose all drug resistance with most of the drugs available for TB treatment. So to summarize, focus on CBNat and TrueNat. So this is a diagnostic algorithm. Always, every time the TB diagnostic algorithm seems very complicated, but it is very simple. So I will summarize it for you. Among a presumptive TB person, that is, presumptive TB means a person with have got a signs or symptoms suggestive of pulmonary TB or extrapulmonary TB or a abnormal chest X-ray. Collect the organ-specific sample. It is not always sputum. With sputum, we cannot make diagnosis of extrapulmonary TB. Okay, so if it is which organ do we suspect? Take the site or specific.
Participants, please mute your microphone.
ज्यादा बंद हो जाएगी एक तरह से लेके पीने वाले में ज्यादा
Continue. Can you mute the participants?
अच्छा एक अवस्था बताओ आइस फ्लू कैसे
मैं कंटिन्यू मैम.
So I lost the flow, especially with the diagnostic algorithm. So first of all, focus on getting the most appropriate organ-specific sample for the diagnosis and send it for NAT test preferred. So again, I am not saying that microscopy doesn't exist. If you if there is a resource limited setting or there is a unacceptable turnaround time with the NAT, okay, definitely for an immediate diagnosis, you can send for microscopy. But in Kerala, currently we are at a position that around nearly 85 to 90% of samples are being directly processed at the NAT. So check for this turnaround time, and if the institution has got a sample collection and transportation system linked to NAT site, and send the sample preferably to NAT site. If you get a result positive, then immediately start the anti-tuberculosis treatment and tag it as microbiologically confirmed TB. So now we know only whether the person has got TB and whether there is a rifampicin resistance. We have got multiple drugs we are using for the treatment of TB. We need to know the resistance pattern to those drugs. For that, we need to send a second sample from this diagnosed patient to our culture DST lab or the intermediate reference laboratory at Thiruvananthapuram. Every state has got these labs under the NTEP program. So send the samples accordingly. And if this NAT or microscopy turns out to be negative, you can repeat the test after 2 weeks of antibiotic and parallelly evaluate for other diseases also if the symptom persists. So if all other test results comes out as negative, the repeat NAT and microscopy negative, but the patient shows certain signs or symptoms highly suggestive of TB with some supporting evidence like chest X-ray, USG, CT, MRI or biopsy, then you can start the person with anti-tuberculosis treatment and tag it as clinically diagnosed TB. But make sure that if we decide to tag that patient as a clinically diagnosed TB, then we also must ensure that the person is taking a full course of anti-tuberculosis treatment. There is no concept like empirical ATT now. That is, let us give this ATT for 1 week or 2 weeks and see if the symptoms are improving. Under the programmatic guidelines, there is no concept like empirical TB. If we start ATT, do our best to ensure that the treatment is completed. So in case of very severe and definitely we can stop the treatment. That's not the case I am saying. But without a decision, don't initiate the treatment. So this is the summary regarding the diagnostics. Focus on TrueNAT and CBNAT. If the patient is symptomatic with a negative test result, repeat the test either immediately depending on the condition of the patient or after 2 weeks of antibiotic. always send a second sample for further drug resistance diagnosis. And for the household contacts, always do a chest X-ray. Not only the symptom screening, do a chest X-ray, rule out active TB, rule out subclinical TB, and then proceed with TB preventive therapy. And the next one, why we are missing patients or why there is a diagnostic delay. At least in Kerala, it is not just because of the health-seeking behavior, but the pattern of health-seeking behavior. The person develops cough, first he will go for self-treatment, maybe, I'm not saying of all patients, but a percentage of patients. If it does not get resolved, he will go to a first doctor. Doctor will advise, may advise for a TB test or any other test, and give a course of antibiotics or the supportives, depending upon the condition, ask the patient to come back. But most of the time, the patient won't come back. He will go to the next doctor, that is doctor shopping. And another reason contributing to the doctor shopping is that non-availability of sample collection facility in that particular institution. So what we have to do is that make use of that first point of contact, that opportunity. Make sure that the person coming with just symptoms, collect a sputum sample, supervised spot sample is enough. Since we are doing a highly sensitive NAT test, send that sample to the NAT site through our sample transportation mechanism. Currently in Kerala, every single institution is linked to a sample transportation mechanism. If it is not so, please do have a word with your concerned district TB officer and ensure that we are not missing any presumptive TB person without offering a test. So this is the treatment current policy on the treatment of drug sensitive TB. No change for the past few years. It is a 6 months regimen. Can be extended for certain extrapulmonary TB, but the drug treatment is not enough for a better treatment outcome. Ensure the adherence to treatment through a treatment supporter. Manage the comorbidities, manage the addictions if it is present. Ensure the patient is meeting the doctor once in every 2 weeks. Ensure nutritional support, because without the nutritional support, we are not going to get a better outcome. Ensure community support and 2-year follow-up for the early detection of any relapse of TB. This is the regimen and the weight band. There is an intensive phase and a continuation intensive phase for 2 months and continuation phase for 4 months. These are the weight bands that we use. And drug-resistant TB, fortunately, with a very good diagnostic coverage, both for the rifampicin resistance and the INH resistance. Fortunately, Kerala is a state with a comparatively lower incidence of drug-resistant TB. It doesn't mean that we have to be lazy on that phase. Always ensure that the diagnostic algorithm is complete for every single patient. For extrapulmonary, ensure that the sample is being put in normal saline. Okay, never ever in formalin. You can take 2 samples or take a single sample, cut it in 2 pieces. 1 sample for the biopsy. It must go to make other diagnosis also. 80% is not going to have TB. Only a small percentage is going to have a TB. And the next part is also going for IRL or the CDST lab. And these are the different category of drug-resistant TB we have, and the concern definition with due to time limitation. I'm not going to the detail of this. I can share the PPT with you. And the different regimens currently we use for the drug-resistant TB. In Kerala, the drug-resistant TB treatment initiation happens at the district DRTB center. And as I said earlier, without community engagement, we are not going to eliminate TB. So these are the certain specific structured community engaged activities, either initiated by the government of India or by government of Kerala. First one, TB Elimination Task Force, something first started in Kerala in 2018. which is chaired by the panchayat president or the municipality or corporation mayor, to address the local determinants of TB and act on it. And treatment support group, again, social people who do all the social works in the community will be formed as a treatment support groups. This will usually focus on a particular patient who feels certain resistance in completing the treatment, maybe due to the social isolation, the stigma, or any loss of wages or poverty, etc. This treatment support groups primarily focus on a particular individual and ensure that the person is taking the full course of treatment. Then to acknowledge the best practices and the achievements of the panchayat, now we are giving TB-free panchayat awards and TB-free urban awards to these local bodies. And the next one is Nikshay Mitra initiative, a very beautiful initiative by the government of India to encourage every single individual, corporates, any institution can adopt a TB patient and offer them whatever support they need. Most of the time, it will be a nutritional support, means I can adopt a particular TB patient and make sure that I will offer a food kit or a food basket to this patient throughout his treatment period. So that's what Nikshay Mitra initiative is. It is not always nutrition, because we have received diagnostic tools, machines, and maybe vocational support, emotional support, volunteers, etc. are all included under this Nikshay Mitra initiative. Next one, Kerala specific LSGD nutrition support project. The local self-government bodies in Kerala will keep project to support every single patient in their LSGD throughout their treatment period. They provide a very high quality food basket worth rupees 1,500 in a month. That will be completely project will be handled by the LSGD department by the support of the health department. So this is a summary of cascade of care in TB. First, there will be prevalent cases in the society or the community. Through active or passive case finding, diagnose all those patients. Then that is through offer microscopy, CBNAT or TrueNAT. And if the person is diagnosed with TB, do the pre-treatment evaluation, do contact tracing, assign a treatment supporter, ensure any financial support for the patient that Dr. Dhilmon will be dealing with in his presentation, and immediately initiate on treatment without any delay, ensure adherence, look for adverse drug reaction, offer TB preventive therapy for the contacts, and finally ensure the patient is either cured of TB or the patient completed the TB treatment. And long-term follow-up, what we recommend is 2-year follow-up for every person diagnosed with TB to ensure that there is no relapse. So these are for some newer updates, not all endorsed by the NTEP in India. Few recommendations by the World Health Organization and a few promising items in pipeline. First one, for screening, we have got a computer-aided diagnostic tools, which we commonly call it as AI-supported chest X-rays or AI-based cough identification pattern, like mobile applications are coming up. Then point of care ultrasound, digital stethoscope to understand easily pick up the early changes in the lungs, and biomarkers such as CRP. And under diagnostics, a new one almost approved by WHO is the lateral flow urine lipo.
Participants, kindly excuse, there is a small technical issue with the voice. Hello, ma'am, are you there?
Can you hear me now?
Voice is not that clear, ma'am.
Okay. I will rejoin.
I think you have already, almost reached the last slide. So, can we conclude?
Am I audible now?
His voice is not that clear, but it's fine, ma'am. You can conclude.
Okay, okay. So the second statement we have more documents coming up. For less than 15 years.
Your voice is breaking, ma'am. Could you please log in again? I mean, leave and rejoin again. Please check your net connection as well.
Is that okay?
Hello, can I speak?
So without getting delay, we'll move on to the next session. So thank you, ma'am, for that enlightening session. So now I take great pleasure in introducing our second speaker for today, Dr. Dhilmon TL, a committed public health professional from Aluva, Ernakulam. He completed his MPBS from Government Medical College, Kottayam, and pursued his MD in Community Medicine from Government Medical College, Calicut. He has served as an assistant professor in Department of Community Medicine at Azizia Medical College, Kollam, contributing significantly to medical education. So he joined the Department of Health Services in 2020 and is currently serving as a District TB Officer and District AIDS Control Officer since October 2025, playing a key vital role in implementing national health programs at the district level. He'll be speaking on grassroots and field realities in TB control. Sir, we are honored to have you here with us. Kindly take over the session.
Dr. Nivya, can I speak 2 or 3 lines about Dr. Aparna?
Sure, ma'am. Sure, sir.
Okay. Myself, Dr. Ramesh Verma. I am professor at PGMS Rohtak, Haryana. No doubt, Dr. Aparna is very nicely and very informative. The PPT she was presented. But I want to add 1 or 2 lines about this TB elimination, because TB can't eliminate without multi-sectoral coordination. So we have to coordinate with other sectors also if we want to eliminate TB by 2030. Rest, Dr. Aparna, no doubt, very nicely explained, and I think she also talk about the, because today is a TB day, and she has not talked about this TB theme of this day. So, Dr. Aparna, next time, please, if it is possible, then please also talk about the theme on that day. Thank you very much.
Thank you, sir. You may continue. You may take over the session, sir.
Okay, thank you for the nice introduction. I'll jump right to the presentation.
Kindly share your screen, sir, your presentation. Dhilmon, sir, sir.
Okay.
Okay.
Sorry. So is it visible?
No, sir. Yes, now it is visible. Please put in the slideshow, sir. Please, yes.
Okay, I'll first talk about the data, then I'll give you a field reality, what is the reality in our district, and what are the challenges. So it will go hand in hand. So first about our district. So just a brief introduction. Our district is Kozhikode district. It has a population of 34 lakh. 34 lakh, according to the 2025 SRS data, and census population is around 30 lakhs only. But current estimated population is 34 lakhs. So we have 6 TUs, tuberculosis units. 6 tuberculosis units in our district, with each catering to around population of 5.8 lakh population. So actually it should be only 5 lakh population, 1 TU per 5 lakh population. So we have more than that. So that's one of our challenge. And we have 32 TB detection centers, previously known as the designated microscope centers. Now it's known as TB detection centers because microscopy has gone out of our diagnostic modality. It is now only used for follow-up only. So for diagnosis, we are using only CBNAT or TrueNAT. So we have only 3 CBNAT sites in our district, out of which only 1 is working currently because of the shortage of cartridges, NAT cartridges. So the one in MCH is only working now. It is used mainly for the diagnosis of extrapulmonary cases, pediatric cases, and HIV cases. And we have 6 TrueNAT cases, TrueNAT sites, out of which we have some demo machines there, so which are currently being taken off. So we have only 6 TrueNAT sites only. That to cater the population of 34 lakhs. That's one of our challenges right now. So we have the state is planning to procure more machines, more TrueNAT machines for each block. We have around 12 health blocks, 12 revenue blocks in our district. So the state is planning to procure a TrueNAT machine for every block. So that will sort out some of our problems. And we have 35 X-ray sites in our district, including 11 in the public sector. We have 3 IGRA sites in our district and 31 step centers in our district. Step centers is a system of TB elimination in private sector. So we have around 31 step centers in our district. And coming to the baseline details, we have 5 STS in our district. In place of we need 7 STS, but we have only 5 in our district, and 6 STLs are there. TBHV all 9 are there. 1 DRTB coordinator and 1 PPM coordinator is there. And we have 144 PHC, FHC, urban PHCs in our district, including 11 urban PHCs, 322 private healthcare institutions, including single MO clinics, 9 taluk hospitals, district hospitals, major hospitals like general hospitals, 9 institutions in our district, 58 IS institutions in our district, and 1 government medical college and 2 private medical colleges are there. Coming to the trend in notification, we have consistently around 2,500 to 3,000 cases per year notified. If you look at the diagnosing thing and current district, so current district means current facility. Current facility means the patients are currently taking treatment from that district. That's the current district. Diagnostic district is the patient comes here for diagnosis only. So from neighboring districts, the patients come here for diagnosis. We have consistently around 400 to 600 more patients coming here for diagnosis alone, and they go back for treatment in their own places. So when we look at the 2025 data, there were around 2,539 cases diagnosed in our district, out of which only 1,998 cases were taking treatment from our district. And we have consistently increased the number of tests during the past 3 years from 90,000 in 2022 to 51,000 in 2025. And around 86% of the tests done were NAT tests, or that includes CBNAT and TrueNAT tests. Microscopy, we are using less numbers. Microscopy is used mainly in private sectors because of the some delay in transporting the samples to the government sector, and that's why they are using microscopy for diagnosis. And if found positive, they will definitely send the samples for TrueNAT or CBNAT. And coming to the public-private notification trends, we can see that consistently equal number of cases is diagnosed or notified from both the public and private sectors in all the months. There is no major difference between the public and private sectors. Almost all equal numbers are from public and private sectors. And when we look at the percentage of notification achieved, we had around more than 90% of the targets were achieved consistently from 2022 onwards. We have achieved more than 90% of the notification targets. Based on the current facility, there were around 2,000 cases in our district last year, out of which 55% were pulmonary TB, 39% were extrapulmonary TB. Some patients were, we could not classify the site of the disease because it was more due to the cases that happened in private sectors. Because of the last stage of disease, they come to the private sector and getting diagnosed, and immediately after diagnosis, or before treatment, they die. So once they enter the outcome as death, we cannot modify the site of the disease. So that's one of the problem with the private sector. We couldn't make them more involved with the enrollment or with the diagnosis part. So with the entry in Nikshay part. So that's one of the problem. And when we look at the bacteriological confirmation of pulmonary TB, 90% of the pulmonary TB were bacteriologically confirmed, only 9% were clinically confirmed. When we look at the extrapulmonary TB, 64% were clinically diagnosed and only 35% was microbiologically confirmed. That's one of the challenges we have now, because we couldn't get the samples from the extrapulmonary side for doing the CBNAT, and there were also shortages in the CBNAT cartridges for doing the CBNAT test. So because of that, most of the cases were clinically diagnosed in extrapulmonary TB. And when we look at the last month's data, 146 cases were notified, out of which 56% were males, 43% females. Pediatric cases were 4.1%. Comparing to the national average, which is around 10%, pediatric cases were almost less. And pulmonary TB was 50%, extrapulmonary is 37%. TB with the diagnosis is TB with diabetes mellitus is 24%. It's almost similar to the prevalence of diabetes in Kerala. And TB HIV was found in 1.4 cases, and only one death occurred last month. Coming to the comorbidities, as I have already told, 1.1% is HIV TB in 2025, and diabetic cases were 25% in 2025. One of the challenges we are facing is the entry in Nikshay. As a result of that, we couldn't get the Nikshay is a very sophisticated app, so there's a lot of data in that. So the private sector, we couldn't make them enter all the things in the Nikshay app. So one of the problems with that is we couldn't locate the patients coming in the private sector. So they are mainly coming to the private sector because of the stigma and also for their privacy. So they wouldn't share the details with us, with the public sector. So we are not able to track them. So the geotagging was only done for 53% of the cases, and out of the 1,998 cases, we could only initiate the treatment on 1,907 cases, and we could enroll the 99 dot slide, which is the adherence monitoring method, we could enroll only 47% of the cases. One of the important thing to be done in the baseline is differentiated TB care assessment. That's we have to check for the lab parameters, the clinical assessment, the signs and the some of the signs, and we can classify them according to the risk as low risk, moderate risk, high risk, and which and the patients needing IP care can be referred for if it is found to be high risk. So that initial baseline assessment cannot be done for majority of the cases. We could do only for 29% of the cases. And one of the problems with this differentiated TB care assessment was it's not directly available in the Nikshay app. For enrolling it in the TB care, we have to go to the Chrome or desktop or laptop. We need that. So the field workers are not well versed in doing that. So that's one of the problem with the differentiated TB care assessment. If it's in Nikshay, they can easily do it in Nikshay. That's one of the problem. So that's why it's very low in number. And we have given NTEP treatment book for all the patients. Coming to the outcome, in 2025, outcome were declared for 1,983 patients, out of which 75% were having treatment success, which is either cured or treatment completed outcome, and around 9% died during 2025. It's consistently, the mortality is consistently around 9 to 10%. It's coming to the national and state average, coming close to the national and state average. Coming to the outcome in based on 2024 cohort, that we have already discussed, 79% is treatment success. That happened in 10.82%. Loss to follow-up is 1.85%. Treatment failure occurred in 0.65%, and still on treatment is 3.65%. Consistently, around 180 to 230 patients die due to TB in our district. That's around 9 to 10%, as I have already mentioned. And the status of DRTB, we have around 66 patients having DRTB in our district in last year, out of which 50 patients were INH monoresistant and MDR-TB was found in 16 of the patients. Coming to the status of TB-free Panchayat, we have one corporation, 7 municipalities and 70 Gram Panchayat in our district, out of which in March 2025, we have declared only 1 Gram Panchayat as TB-free. In this year, we have submitted claims for 1 municipality and 7 Gram Panchayat for TB-free status. Coming to another strategy, that's Nikshay Mitra, as Dr. Aparna has already told, Nikshay Mitra deals with nutritional support to patients. Out of the 2,000 patients in our district, 1,382 patients have given consent for the nutritional support, but we could supply only 186 kits to these patients. That's 87 patients got the nutritional kit last year, and out of the 78 LSGDs, local self-governments, only 30 have approved project on nutritional support, and only 14 has initiated the food kits distribution. Other Nikshay Mitras include the staffs from the Family Health Center. State Bank of India has already provided the nutritional kits to some of the patients. Trade organizations are also providing nutritional kit. District collector is also supporting one patient. Our district medical officer is also supporting one of the patient, and one of the organization in Balsheri is also supporting the patient. So Nikshay Mitra was this initiative was introduced in the year 2022. We couldn't get any Nikshay Mitras in 2022. In 2023, we have 33 Nikshay Mitras, and it has risen to 186. And we have distributed 186 kits in last year. This year, we have started on a positive note. Our corporation, the Kozhikode Corporation, has already given 170 food kits to the TB patients, and 15 LSTDs have already started the nutritional kit distribution to the TB patients. Coming to the newer initiatives, as Dr. Aparna has already told, the TB Mukt Panchayat or TB Free Panchayat is one of the status, one of the newer initiative, and we are already scoring the states based on the TB index, based on 9 indicators, and if there is more than 20% decline in TB incidence, they will get a bronze medal. If there is 40% decline in TB incidence, they will get a silver medal, and if there is 60% decline in TB incidence, they will get a gold medal. And if the district is having more than 80%, more than or equal to 80% decline in TB incidence, they will be declared as TB free district or city. Another new initiative is Nikshay Mitra, that's launched in 2022. TB champions and Vijayda were, that's already the patients who have completed the treatment or who are declared free. They can be used for motivating the patient. They are called TB champions of Vijayda. This initiative was launched in 2024. Differentiated TB care was started in 2022. 100 days TB campaign was that's intensified TB screening and diagnosis. That's 100 days TB campaign that's launched in 2024 TB Day. Programmatic management of TB preventive therapy was launched in 2021, and BPAL regimen, that's a newer regimen for MDR TB. It's a shorter regimen. Initially, it was for MDR TB, we were using injectable drugs, and longer duration, up to 2 years, we were using. With the initiation of BPAL regimen, now it's the duration has come down to 6 months. So, based on the eligibility, we are starting BPAL regimen. BPAL regimen is bedaquiline, predominate, linezolid, and there's a M also is there. There's moxifloxacin. That regimen is given for MDR TB, 6-month regimen. And coming to the DBT schemes, we have Nikshay Poshan Yojana for all the patients notified. If the patient is confirmed to be TB, whether they are drug sensitive or drug resistant TB, he or she will get 1,000 per month. It's usually given in 2 installments, 3,000 at the beginning of the treatment and 3,000 after completing 84 days of treatment. It's given for all the public and private sector patients. If they have consented for receiving the benefit, then they will get the amount. There's also a tribal support scheme for the confirmed TB patients residing in tribal TU. It's rupees 750. It's a one-time installment given for the tribal patients. Treatment supporters honorarium given for treatment supporter. It's usually given in the rate of rupees 1,000 for drug sensitive TB when the patient has completed treatment, and rupees 5,000 for drug resistant TB patient when the patient has completed the treatment. And incentive for notification and outcome is given for private health facilities, can be given for private practitioner or clinic, or hospital, clinic or nursing home, laboratories or chemists. For those who have for those who are notifying the TB cases, given in the rate of at the rate of rupees 500 as informant or notification incentive and rupees 500 for outcome declaration. So these are some of the activities we have conducted in our district last year. We have a state task force meeting involving all the medical colleges. We have consistently given training for all the field staff, including the mid-level service providers, junior health inspectors, lab technicians, nursing officers, pharmacists. We are consistently screening the patients or migrants. It's an integrated health camp involving all the along with TB, we are consistently screening for HIV, NCDs, TB, diabetes, hypertension. Also, along with malaria, also we are screening for migrants, and that's one of our positive thing. We have received 170 kits from the Kozhikode Corporation, and we have last year completed TB pre-panchayat status for 8 LSTDs. We have verified that. Some of the concerns we have is that we have, as I already mentioned, we have at times we have shortages of the cartridges. That makes it difficult in diagnosing the cases, and there will be delay in diagnosis. So the turnaround time will increase. Usually it will come around 5 to 7 days. The CBNAT test will give result in 2 hours, but TrueNAT also gives test result in 2 hours. But the patient load and the number of samples, we cannot manage these things with this number of machines. And the challenge is private sector diagnosis center. So some of the patients from other districts come to our district for diagnosis for the privacy and because of stigma. So we cannot contact them despite repeated requests to the private sectors. We are not able to come in contact with these patients. One another challenge is we have handheld X-ray in our district, and we are able to procure one handheld X-ray, but it's not yet operational because of the concerns of radiation. We cannot use it for the entire vulnerable population, migrant population, as well as the tribal population. And the handheld X-ray positivity is the sensitivity is very low, so that's one problem. And one problem we are facing is contact tracing and initiation of TBT. That's because of the resistance from our patients. We are not able to trace the contacts, not able to initiate TBT for our contacts because of the resistance in some patients. And we are, as I have already mentioned, the differentiated TB care module in the Nikshay app is not there, so that's becoming difficult for entry. And we have very less number of beds for IP care. That's one of the concern. And one big problem is Nikshay. That's a huge app with huge number of data. It's not able to. We are not able to accurately catch all the data at the same time. That's one of the concerns. So with that, I'm concluding my presentation.
Thank you, sir, for that practical and highly informative presentation. We will now move on to the Q&A session. We'll project the questions which you have got in the chat box. I think the few queries has been addressed by Dr. Aparna ma'am in the chat box itself.
If I am audible, I can answer it here itself.
Yes, ma'am, you are audible.
Okay. Okay, which state has the maximum caseload in India? According to the National TB Prevalence Study, I have mentioned per lakh population, the highest 5 states with where the prevalence of TB is very high is Delhi, then Rajasthan, then UP, then Haryana and Chhattisgarh. This is per lakh populations, but so definitely if you see the actual figures, maybe UP will be the topmost, nearing around 7 lakh patients diagnosed and reported in a year. Next question, sensitivity and specificity of CYTB test. First, to comment on sensitivity and specificity, we need to have a gold standard test. But unfortunately, for TB infection, we do not have a gold standard test. So IGRA was the first test developed and approved by the WHO for TB infection. There, the comparison was done with TB culture, and definitely that was done among TB patient also, but not for the TB infection. There, they proved a sensitivity and specificity of around 95%. When the CYTB evaluation was done, actually Kerala was also a part where the diagnostic test evaluation of CYTB was done. And here we compared with the IGRA, and we got a comparative of 95% sensitivity and 95% of specificity in comparison to the IGRA, not to any other gold standard. And please explain about the effectiveness of BCG vaccination in disease prevention. BCG vaccination have a 60 to 80% of effect in preventing pediatric TB, and definitely it's very severe forms like miliary TB or disseminated TB, and among adult age groups, or they does not have a proven evidence. But in India, now the government of India has taken up a study, not a study, actually in the implementation style itself. In many of the state, adult BCG vaccination is being given to see how it is going to support us in preventing adult age TB. Then definition for contact or reference for the same. The definition given in our programmatic management of TB preventive therapy guidelines is that household contact or a contact is any person who has shared the same enclosed living space with a person diagnosed with infectious tuberculosis for 1 or more nights or frequent or extended periods during the day within the last 3 months prior to the diagnosis. So I will add the same in the chat, so you can check there also. Is ITB test available throughout the India, or is it superior to IGRA test? The first question, it is being supplied by the National TB Elimination Program to those states and districts who follows the test and treat policy. As I said earlier, there are certain places where they do not go for the TB infection test, just do the active TB rule out session and then directly goes for the TB. Okay, if your district is ready for a test and treat policy, or the state is ready for the test and treat policy, then definitely the program itself is providing the CYTB. Is it superior to IGRA test? Technically, no. Technically, both are comparable, but practically, CYTB is superior because the IGRA, the cost is very high. It required trained lab technician. It required a very good lab facility, blood collection and sample transportation mechanism, etc. But for CYTB, it is a point of care test. A trained healthcare worker, a staff nurse, etc. at the peripheral health institution can do the test. So practically, it is superior. Technically, no, it is just comparable. Is there any screening for vulnerable group like migrants? Yes, the same way we do either the symptom screening or the X-ray screening. They're all included under the vulnerable group, definitely. So the screening modality remains the same. How effective are AI-based TB detection strategies at a mass scale? See, as of now, we do not have AI-based TB detection strategies. Currently, we have only AI-based TB screening strategies. Okay, so the handheld X-ray devices supported with AI, we cannot say that is actually not artificial intelligence. It is just computer aided detection. Because if the chest X-ray is taken, then it will give a report that the chest X-ray is abnormal. So this is just a screening to filter out the high probable people, and followed by a NAT will give a diagnosis of TB. In resource limitation for a mass screening and everything, this is going to be a great help. Should we retest the latent TB patient on completion of TPT for ensuring clearance of latent TB infection? No, because we cannot say that person that IGRA can be completely negative or positive, because there is it is all depends on the immune status of the person, and even a remote exposure and the sensitization can again give a false positive. So we do not recommend for a repeat IGRA to ensure or statement like cured. TB infection has only one outcome, that is treatment completed. We never say that cured of latent TB. How many times TPT can be given for recurrent latent TB status? As of now, the programmatic guidelines, we say that it is one time, but we all know that it is not going to have a effect like a vaccine, because we just cleared whatever infection we had. It is not going to prevent a repeat exposure. So definitely in Kerala, what we practice is that if a second exposure is very evident, that is another close contact of this person who already took one course of TB preventive therapy, got a high exposure again, definitely we will give one more course of TB preventive therapy, considering his risk status for a future TB, or actually risk versus benefit. How much he is going to benefit from a second course of TPT, or is there a risk for TB in the future? So all questions addressed or anything pending?
A few questions have come in the chat box, ma'am. Any initiatives done for prison inmates, which is a high-risk group?
That's similar to migrants. There also we do the same. In their settlements, we will conduct the screening and X-ray screening. And for presumptive TB definition, are we using the previous 4 symptoms or the Nikshay Shiver 10 symptoms on routine basis? So currently we are focusing on 10 symptoms, because we need to get maximum number of presumptive TB individuals. So we are giving wide publicity to this 10 symptom screening now. What should we advise the patients on disposal of sputum at home? I do not know from where this question came, because in Kerala, what we do is that we have got an airborne infection control kit that we offer to every pulmonary TB patient upon the diagnosis. Okay, definitely there are disruption in supply chain management. But what we ask is that there will be a spittoon. We will ask the patient to fill that 1/4 of the spittoon with the phenol, and put all the expectoration in this spittoon, keep it overnight or many hours for that contact period, and then flush it off in the toilet. That's it. That's how we have to dispose the sputum at home safely.
Thank you, ma'am. I think, yeah, few more questions for from the second session. Dhilmon, sir?
Yes, sir. STEP Center. It's a system of TB elimination private sector. So any private sector having TB patients where they are diagnosing TB patients, or any private sector, any clinic where they are treating TB patients, can be enrolled as step centers. So they will keep a presumptive TB register. They will enroll the patients in the NICSHE, or they will send the patients to the public sector, or they can exchange the data with the public sector, with the district TB center. They are enrolled as step centers. So that's step center. And what is non-classified TB? So as I already mentioned, we have pulmonary TB and extrapulmonary TB. So this non-classified is happening mainly because of the lack of entry in the NICSHE. So when the patients come to the private sector, mainly in the private sector, they will just pick the patient as test positive only. They will not mark the site of the TB. So that will go as non-classified cases, and mainly in the cases which are mainly in the death cases, we will not be able to edit these cases. So once the outcome is declared, then we will not be able to edit these cases. So they are going as non-classified TB. And how to declare as TB free. So for TB free status, we are considering 6 indicators. Indicator 1 is presumptive TB examination rate. For a village, that should be more than 30 tests, 30 presumptive TB examination tests per 1,000 population. And second indicator is TB notification rate. It should be less than or equal to 1 case per 1,000 population. Indicator 3 is treatment success rate. It should be more than 85% of the notified cases. Treatment success includes both cure and treatment completed. Indicator 4 is universal drug susceptibility test. It should be more than 60% of the cases, TB cases. Fifth indicator is NICSHE portion Yojana. It should be given to all the patients. That's 100% of the patients should get the NICSHE portion Yojana. And the sixth indicator is nutritional support or NICSHE Mitra. It should be given to all the patients who have consented to receive the nutritional kit. That is 100% of the patients should receive the nutritional kit if they have consented to receive the nutritional kit. And what are the initiatives taken to tackle the mental health challenges? We are consistently in contact with the patient, whether they need any counseling or any support. We are offering them the support, and whether they need any help also, we are ready to help them. So, and we are linking them to the treatment supporter as well as the NICSHE Mitra. So that will take care of the mental health aspect of the patients. Okay, I think I have covered all the.
Yes, sir. Thank you, sir. I think almost all the queries have been addressed. So it's time to wind up now. Yes, so I take this opportunity to express my sincere gratitude to the management of KMCT Medical College and our respected principal for their constant support and encouragement, and our HOD, Dr. Jayakrishnan, sir, for his inspiring leadership, and our esteemed speakers, Dr. Aparna, Mohan, ma'am, and Dr. Dhilmon, sir, for their valuable time and highly insightful sessions. A special note of thanks to Dr. Shami and Dr. Arvind for the excellent coordination of the program. And I would also like to acknowledge the faculty and residents of our department for their valuable support, the IT team and the technical staff for ensuring the smooth and seamless conduct of the webinar, and all supporting staff who worked behind the scenes. And finally, all the participants for your enthusiastic and active participation. Thank you all once again. And before we conclude, we kindly request all participants to fill the feedback form which has been shared in the group, and the recorded video of the session will be uploaded on our official YouTube channel, and the link will be shared in the WhatsApp group. So please stay connected and stay tuned for our upcoming webinar series 3 on NP-NCD, which will be on April 7th. Thank you all once again for your participation. Have a wonderful evening. Thank you.